Good afternoon, everyone, and welcome to the Wolverine Caucus Forum series. And we're so excited to see all of you today and to let you know that these forums are generously brought to you by the generous support of the U of M Alumni Association, as well as the Office of the Vice President for Government Relations. We like to think that we're changing the world one forum at a time. And today, we are excited to talk about healthcare affordability. We couldn't have been graced with more illustrious speakers than we have today. And without further ado, we're going to ask State Representative Martin Hawrylak from the great city of Troy, who's on the Appropriations Committee. He's chair of Fiscal Oversight. He's on the Education Committee, and he is on the School Aid Committee. And with all of that, he took time to come today to introduce our speakers. So without further ado, and did I mention he is an alum, so go blue, Representative Hawrylak.
Thank you all for coming this, I guess it's still morning. And I'll be brief in my introduction, but I just wanted to share a couple of little things with you. And the life of a first-term legislator is interesting, and so today is another first for me. This may seem amazing. This is the first time I've actually been in a Senate office building, so this is my first time in the Farnham building. I mean, obviously, I spent a lot of time in the House office building, and I'm still finding out where bathrooms are hidden in the Capitol as well. So, the life of a first-term legislator. I am indeed a University of Michigan graduate, and when I get a cut, I bleed maize and blue. So I can assure you that the university is very near and dear to my heart. The one thing I would like to see before I leave Lansing is to have the Wolverine Caucus meet in East Lansing sometime. I will take a moment here to introduce Dr. Darrell Campbell, and he is with the University of Michigan Health System. And just a personal note, I will tell you that my sister graduated from the University of Michigan Medical School in 2003. And so not only do I have a great affinity for the university, but specifically our family has a great affinity for the university medical school as well as the health system. But and I have my little cheat sheet, so Dr. Campbell is so distinguished that I must admit I cannot remember all of these things, so I will look down occasionally. But Dr. Darrell Campbell, Jr., MD, is the Chief Medical Officer at the University of Michigan Health System. He's also a professor of surgery at the Department of Surgery and has for many years specialized in solid organ transplantation, particularly kidney, liver, and pancreas. As the Chief Medical Officer, Dr. Campbell is responsible for the overall quality of care delivered at the University of Michigan Health System and has special interest in patient safety. Dr. Campbell received his Bachelor of Science degree in zoology from Michigan State University in 1968 and graduated with distinction from George Washington University, receiving his MD degree in 1972. Subsequently, he received his general surgery training at our beloved University of Michigan Medical School from 1972 through 1979. He served as the elected Chief of Staff at the University of Michigan Health System from 2001 to 2010, during which time he ran the Office of Clinical Affairs. In 2010, Dr. Campbell was appointed to the newly created position of Chief Medical Officer of the University of Michigan Health System. So without further ado, I will turn over to the podium to the very distinguished Dr. Darrell Campbell.
Thanks very much, Arden. Is this working? Yeah, now it is. I'm happy to be here. This is fun for me, and I think this is when I look back on my career, I'm not operating on people now like I used to, but what is satisfying to me, and satisfying to me now is thinking kind of big picture and translating what we do in medicine to folks who don't do medicine every day, and that's why we're here today. And so I hope you find this interesting, and want to thank Director Haveman for being here, and Nell and Rick and many of the rest of you in this group who've listened to what we had to say and have been really attentive to some of the concepts here that I'm going to talk to you about in just a few minutes. So I'm going to stick my neck out a little bit. I don't think this works. Can you hear me if I just talk? And I'll talk loud. Okay. So I'm going to stick my neck out and just tell you a joke to start off with. Because surgeons are kind of, a little eccentric in some ways, and I'll introduce Michael in just a minute, my younger associate who's also a transplant surgeon, but the one thing we kind of pride ourselves on is being hard workers. So this joke will kind of underscore that. And so imagine a team rounding in a hospital. There's a professor and a chief resident and an intern, the lowest part of that team. And they go into a patient's room, and the patient's not there, but they see a funny-looking vase on the table next to the bed. And the intern picks it up, and suddenly a genie comes out of the vase. And the genie said, I'm very, very grateful to you for letting me out of this thing. I've been in it for 1,000 years, and I'm going to grant each one of you a wish. And so he looked at the intern, and he says to the intern, what's your wish? And the intern says, I'd like to be on the beach at Acapulco sipping a daiquiri. And poof, in this puff of smoke, he's gone. And then he looks at the chief resident, and he says, what's your wish? And the chief resident says, I'd like to be in the winner's circle at Monaco, having just won the Grand Prix, and Princess Grace comes down and gives me a big kiss. And so he's gone. And then he looks at the professor of surgery, and he said, what's your wish? And the professor thinks for a minute, and he said, I want those other two guys back here by noon. So that's the work ethic culture that we like in surgery. So, but I want to be a little more serious now and tell you about this particular subject. We titled this, Can We Get Healthcare for Less? And how can we structure our healthcare delivery system to accomplish that? So, the president has asked us, regardless of what your political leanings are, I think everybody would agree that we're supposed to improve quality and reduce cost. And the question is, how do we do that? And that's what I'm going to be talking about. We think we have a new approach to that could be helpful to people of the state of Michigan. So you could probably all accept that surgical costs are a large part of the overall medical care budget. These are big procedures, and they're expensive, and they contribute a lot. It's probably 40 or 50% of the total bill for healthcare delivery. And the second thing I want to emphasize is that, and you probably won't have any trouble accepting this, but it's better surgical quality results in fewer costs. That is, if we avoid a complication like a pneumonia after surgery, somebody's saving money by avoiding that complication. And you probably also wouldn't disagree that surgeons are in the best position to figure out how to improve surgical quality. That's not something that can be done by a federal bureaucracy or something like that. The surgeons, it has to come from the surgeons. So now I'm going to switch gears a little bit to this. I took this picture in the basement of Starbucks in Ann Arbor a while ago, and it made me think about how we learn things these days. When I was an undergrad at MSU or in medical school, I went to the farthest stacks in the basement of the library with a bunch of books and tried to concentrate on learning myself. But that's not how the students do it these days, and arguably this is a much better way of doing it. You can see the picture here, it's hard to see, but they've all got a computer, so they're connected electronically to every resource in the world, and they're sitting around together talking about how to solve their problems. And I think you end up with a better kind of result when you do that. And we've tried to do that in this new system that I want to tell you about. So this is a map of the state of Michigan. And every one of these names here is a different hospital that participates in our system. And the system's called the Michigan Surgical Quality Collaborative, and it's supported entirely by Blue Cross Blue Shield of Michigan. It pays for every dime of what we've done. But it's in their interest to do it too, because they want to improve quality and reduce costs just like we do. But the point of this slide is that these 52 hospitals are connected electronically just in the same way those students were. And we get together to talk about how to solve problems rather than trying to do it individually by ourselves, which was the way that we've done it forever in the past. And in fact, it's been competitive in the past because hospitals, when they find out something that's good, some secret sauce that they've discovered that helps improve patient care, they weren't particularly interested in sharing it with their competitor across town because that gives them, they're giving up their competitive advantage. So that's a kind of incentive we don't want to have. So the idea that all these hospitals are together is a good thing. Well, the other part of that's really important is that we have to have a way of communicating apples to apples. So we've developed a system for measuring quality in the state that's the same from hospital to hospital to hospital, so that we can really say who's doing something the best, and if we can find that out, let's share it with the rest of the hospitals. And that would seem to be very, very obvious, but it has not been the case in the past. And this, I don't think it shows up terribly well here, but this is just an example of the kinds of, communications that we do. This is an example of a quarterly meeting that MSQC has. Every 3 months we get together, representatives from all the 52 hospitals, which includes surgeons and nurses, get together and we share those best practices. And so that's a really important aspect of the thing. There was a famous study that came out a while ago that showed that when you discover something of importance in medicine, it takes an average of 17 years for it to get disseminated throughout all the rest of the medical community. 17 years, that's a long time. And we can do it much more quickly like that, when we get together like this at a quarterly meeting and through our website, which is very active. So that happens every few months. And a really important thing that never happens short of an organization like this is the site visit. And what that means is that when we find out somebody's doing something really well, and if the left part of this slide right here shows a graph, and on the y-axis is the rate of a particular kind of complication, let's say an infection of your surgical site. We don't want that to happen, but it sometimes happens. So that's on the y-axis. The higher is worse. And on the x-axis is all of our different hospitals. And so we provide this information through our electronic system. They can get it anytime they want to look at it, and they can see where their hospital is. Now, they don't know who the other hospitals are. That's a key feature here. We've got to make sure that it's confidential, but you can see where your hospital is in the continuum of quality here. And the most important part of this slide is that you can see where the best performers are. Now, these hospitals down here didn't have very many infections. They're doing the same kinds of operations. In fact, we standardized for that. That's adjusted for. They're doing the same kind of operations, but they didn't have very many infections, as opposed to these hospitals over there. A lot of their patients were getting infected. So why is that? And that's the value of the site visit. So we take our team, we're going to do one next Monday, and we show up at the hospital that's doing very well, one down here in the bottom here. And we say, you don't have very many infections here. What are some of the secrets that you think are important that the rest of us should know? And sometimes they're not really sure, and so we do an inventory of all the things that they're doing. They didn't even know that they had a low rate of infections compared to everybody else. But we tell them that, and then we take our notepads out and we write down all these things. And then the next quarterly meeting, we very frequently have a panel where we get them up on the stage, and then people can quiz them about what they're doing, and in this way the information gets transmitted very rapidly. And I would argue that there's no other way to do that. If you go to a typical surgical meeting like I've done for the last 30 years, it'll be a big crowd, 300 people, surgeons sitting in the crowd, and somebody will give a paper for 7 minutes, and then there's 3 minutes of discussion, and then everybody sits down again. And that's not an effective way to get that information out there, because it just doesn't diffuse throughout the surgical community very quickly. And there's a certain team building aspect that I like to these site visits too. So we can get to know all the people, they can get to know me, I can get to know them, and that builds a certain degree of camaraderie, which I think is helpful. And so then we take these best practices, what's the best practice that you have? For instance, if you want to avoid blood transfusions, unless you're bleeding to death, it's not good to get a blood transfusion. So there are hospitals that have, put protocols in place that were particularly effective in reducing the number of blood transfusions. And so what is that protocol? So we say, can we borrow that? Oh yeah. We put it on our website, and they can look at the first one up there, blood transfusions. That's out there for the rest of the 50 hospitals to use, and you don't have to reinvent the wheel. You can just say, okay, it worked for them, we'll make a few modifications, and now we'll use that protocol. And that's a huge time saver for these hospitals. So over the years, as we've been developing this for the last, 8 years or something like that, here are some key concepts. One key concept is it has to be friendly. This is not a competitive environment, or if it is, it won't work, frankly. But there has to be a certain level of trust to this, and there's a picture of myself and Shukri Khoury, who I think was the friendliest man I ever met. He's a Lebanese surgeon, but he was a professor of surgery at Harvard, and he sort of started this whole idea of collaboration among surgeons. And his concept was that, this is something that we're trying to solve together. We're not trying to, get a leg up on the next guy. And I think that's really important. And it generates sort of a non-competitive kind of environment where people are willing to share what they do. And as a matter of fact, if you don't have that kind of environment, they're not going to let you into their hospital to do one of those site visits, because why would they? They might be afraid that you'd take their good idea and put it up on a billboard someplace and advertise their own hospital. Well, you want to get away from that kind of thinking to something that's much less competitive than that. So there's a lot of trust that needs to be developed. But I think I put these clasped hands, that you can't see it very well, but there's blood coming out. It's a blood oath. And we make them take sort of tongue-in-cheek a blood oath that we are not going to use this information for competitive advantage. We're not going to put it up on a billboard someplace. The information that we share, in the four walls of our meeting is going to be confidential information. And it's not going to go outside. And there aren't any secrets among our group. And so I tried to set the tone about that. In one of the first meetings we ever had, I stood up on the platform and I said, I'm from the University of Michigan. We got a terrible problem right at the moment with infections of a certain kind. Somebody help me. And I think that's the kind of attitude that you have to have without fear that, somebody that's going to get outside the meeting room. So this might be a take-home slide from what I'm telling you right here. Here's how you improve surgical quality, something that surgeons know how to do. Develop a surgical registry. We did that. We've got it, there's a book full of definitions, and we trained the nurses in how to pick this stuff out of the medical record. And then we use that registry to examine the variation in quality, who's the best and who's the worst. We identify the best performing hospitals, and then we go to the site and we find out what the best practices are at that site, and then we distribute the information. It's as simple as that, but it hasn't been done effectively in the past. So as I look back on it and think about what are some of the important features of this kind of arrangement, I put a list here, which I won't go through all of these, I guess, but I think the financial support on the left side is really important. We wouldn't have gotten anywhere if we didn't have a source of funding, and then the blues came through pretty convincingly with that. Data has to be reliable. I mean, surgeons are huge critics of data. I mean, if they don't think the data is correct, they are not going to act on it. So you have to have, procedures in place so that they believe that data. And then I think what's really important is we have to have a regional organization. It has to be a regional sort of structure, because if it's not, if it's a national structure, and there are national structures sort of like this out there, they're not very effective. And the reason they're not effective is because nobody knows anybody else from the, I don't know any of the surgeons in Iowa, so it's hard to get together with them and share at the level we need to share. It's just more difficult to do. So I think this regional idea, and the region that, our region obviously is the state of Michigan, that is doable, because we can, the distances aren't that great. We can get together every 3 months. Over time you get to know them pretty darn well. And frankly, half of them graduated from the University of Michigan, so we do know a lot of them there. And then we have this multidisciplinary approach to it, which I think is really important, and so forth. So, but the most important point is the culture that results from that is one that's non-threatening and non-competitive. And then the last bullet I've got down there, I asked Mike to talk about this in a minute, but this idea is that we don't want to do the same old thing. We are not interested in just repeating what everybody's done in the past. And so if we don't have creativity and innovation built into this system, then we might as well just go home, because nothing new is going to be learned. And so that's the platform for that creativity and innovation is something that's really important. So the question is, how does it work? And I kind of explained that. I won't go through all the details, but on the left side here, you see the 52 hospitals in MSQC. That data, the nurses collect the data on the cases that we're interested in. And then they send that data to a contractor in Boston called QC Metrics. They clean the data. They make sure it's, nobody's age is entered in as 400 years, that kind of thing. And so they make sure the data is good. And then it's sent back into a different contractor called Arbor Metrics. It's in Ann Arbor. It's a startup, actually, at the University of Michigan. And then they analyze the data and put it back on the website so everybody can see how they're doing. And they make these cool slides that have a dashboard where you can see. The only thing I want you to take out of this is that you can see in the green here is your site, and the yellow bar is everybody else in the state. So you can see where you stand with regard to any number of different parameters of surgical quality. That kind of information is real time. You can get that anytime you want to, and it's very, very important. And you can, computers can show it any way you want to, but I think this kind of diagram here is very important, where you've got all these hospitals, you've got a risk-adjusted mean, and then you've got error bars, and you can see where your particular hospital is in this. We're all very competitive. If we're on the wrong side of that graph, we're not very happy. We're going to do something to try to make that better. And then you can trend it over time, and any number of ways you can see it through a modern, computer age. And now this is just to emphasize this idea. We get together routinely, and Director Haveman might recognize this because he's sitting up here very close. But this is he right here. You can't see that, but he was kind enough to come to our annual conference that we had in Traverse City last year and try to make this link between the Department of Community Health and what we're trying to do on a statewide basis for surgery. But we do that quite often, and that's one of the more important things that we do. So here's the bottom line. Does this work? It sounds great, but does it work? And I would argue that absolutely it has worked very, very well. When we've measured from the very big picture, we've seen this 20% reduction in the incidence of these very important surgical complications over time, and a concomitant reduction in the length of stay that patients are in the hospital. And if they don't get sick, nothing bad happens to them, they get out earlier. And then the most important thing, I said we had to improve quality and reduce cost. Well, we've done that. And the Blues actually did this analysis with that. And here's the logic, that a complication costs somebody money. If you get a bad pneumonia after you have your gallbladder taken out, that you have to be in the hospital a lot longer. You might need to be on the ventilator. You have to get expensive antibiotics, all this nursing care. It's costly, and in fact, it averages about $45,000 per case extra money if you get a pneumonia. So if you can avoid getting pneumonia, then somebody has saved some money. And when we extrapolated through all the kinds of complications that we measured throughout the state, it looked like we'd saved $85 million in costs from these avoidable complications to Blue Cross Blue Shield. So their return on investment was terrific, and they've liked that. And so we published this. There's a journal, it's sort of a health policy journal called Health Affairs. We published that and made some conclusions here, and the conclusion was that the regional collaboration between a hospital and the physicians might be more effective than either selective referral or pay for performance in improving the quality of healthcare at the population level. So I think that's the most important thing. You have to have a regional organization for this kind of approach. And then this slide is this blue line is the improvement that we've seen in MSQC, and the red line is the improvement that was seen in outside of the state of Michigan using essentially the same measurement model. So the point, I think that speaks to how this regional and collaborative kind of organization is more effective. Now, the one thing I really am excited about and want to get to quickly is the concept we're not just measuring quality, we're not just measuring cost, we're measuring them together. And that concept is the value proposition, which I think everybody can appreciate how important that is. Value is defined as quality divided by cost. And so what you would like to be in, if you're a hospital, you'd like to be high quality, low cost. You would not like to be in low quality, high cost. And so we're now starting to make this presentation where you have these quadrants where there's risk-adjusted complication rate on the y-axis and these quadrants right here, which is cost of care on the x-axis. And so you can see where your hospital stands with regard to this value equation, which I think is incredibly important, particularly to the hospital administrators who want to know that. And so, again, you can find out the best practices. Who are the hospitals that are in the high quality, low cost quadrant, and what are they doing such that they're in that quadrant? I think that's really important information. So this, you can't see it very well, this just shows you we did win an award, a national award from the Blues about this whole project. So I'm going to skip that. And I'm going to get to the end here, and then I want to turn it over to Michael. But so we started to see surgical care as more of a continuum rather than just, in the past, it's just been prevention of complications. That's all we concentrated on. That's very important, as I've said. It's not the only thing. The second part that we started to think about is what about, once you do have a complication, what about rescue from that complication? And hospitals differ in how well they do that. Some are really good at rescuing you from a complication. Others are not good at all at that. And so we started to measure that. That's a new concept. And it has to do with how much resources the hospital is putting into their, like nurse staffing and the code teams and rapid response teams and that kind of thing. So these are things that are important in the hospital level. But now we try to broaden our thinking a little bit and think about what's the optimum preparation of a patient who's about to undergo surgery. That's really important. And let me tell you, surgeons have not paid attention to that in the past. So if you're going to have a big operation, shouldn't you do the things that you can do to get in better shape? And that's what Michael's going to tell you about. This is really his innovation, which I think is important. And you can't see that either, but there's a picture of a boot camp. We call it boot camp, and trying to get in the 4 or 5 weeks prior to an elective case, how can we get you in the best shape possible so you have the best chances of surviving with an uncomplicated course? And that is a way that surgeons can link with the primary care community, which we have not been good at in the past. They don't know what we're doing, and we don't know what they're doing. So we want to link with the primary care community, and that's this box right here, collaboration with the community. So that's why when Jim came up and talked to us last year about the Department of Community Health, we started thinking about that, about how we could fit into plans at the statewide level. And this is a slide that's sort of preliminary draft, but we're putting together this state innovation model, the grant to the federal government. Hopefully they will think our plan is good, and it's a very comprehensive plan. It's not just surgery, obviously, but what the idea would be, or at least my idea would be, that the care coordination hub, which is the sort of central part of the state planning grant. How can we coordinate all these many different services, mental health services and all sorts of different things. How do we coordinate it better? Well, one aspect of that is coordinating it better with the surgical specialists. And the reason that I think that it's important is because 40 or 50% of you are going to have a big operation at some point down the road. And it's a big, and that's costly. So we can make some improvements there. So that's the part of it that I'm trying to advocate for, that the care coordination hub involve enhancing that relationship with the primary care doctor in a way that helps everybody. So I'm going to stop talking now. That's sort of the big picture of what the MSQC is. And I want to introduce Mike Englesbe, who is my younger partner, but he's also a transplant surgeon. I've known him for years, and he's a terrifically talented, bright person with a lot of great ideas. Graduated from our University of Michigan surgical training program, but is a Yale graduate, as an undergraduate. And Mike's come up with some really interesting ideas about how we can really prepare people better for surgery, identify people who are particularly high risk for having complications, and try to make them in better shape.
Okay. Thanks, Dr. Campbell. Excuse me. Thanks, Dr. Campbell. So I've been in Ann Arbor for 17 years. Dr. Campbell ran the general surgery residency when I applied out of medical school, and I've been working for him since. So, and I actually was sitting there watching, and I frequently am called kind of younger Dr. Campbell, which is a great compliment, but I noticed we actually have...
With more here.
Yeah, we actually have the exact same clothes on today, with the exception of a different tie. Like, and I have no doubt if you look at the labels, they're probably from the same stinking store. So that was not intentional. So what I'm going to talk about is kind of building on what Dr. Campbell had mentioned. We have this amazing platform in Michigan that Dr. Campbell has built in collaboration with Blue Cross, and we measure things and we talk about it. But how can we use this platform kind of as an impetus for some really novel ideas on how to better take care of patients? So the goals of my talk are kind of to explain our strategy and how we got to where we are. I'm going to quiz someone. I'm going to have to take a volunteer. This is audience participation. And any physicians in the room? No? All right. The young, smart-looking guy in the back, I think, I'm going to pick on you. So I also run medical student education. So I'm always like, I don't know, I'm always trying to educate. And then I'm going to try to link it up with kind of what our ambitions are in the state. So my clinical practice is in liver clinic, and I think that shows up. But long story short, this is my clinic, and this is the day I'm walking down the hallway, and I'm looking at where I'm going. I do liver transplants, and I look outside the room, and every stinking room has a wheelchair. And transplantation is generally for younger patients. If you're over 70, you don't really get a transplant. It just kind of goes to show why do people do lousy with surgery? And you kind of think it's heart disease or diabetes. It's not. And I'll explain that it's essentially some of the innovative things we've done kind of help us understand why people do lousy. So when you have an operation, I'm sure many of you have had one, you can't have a big operation without a CT scan or an MRI. Pretty much that is a rule. And you have, there's another piece of data too, that a third of all kind of computer storage space in the world is medical images. And that's on an IBM commercial. So I don't know if that's true, but I'll reference the commercial. So there's all of this data that sits out there, and what do? Who's had a CT scan or an MRI? Yeah, of course. And that data is somewhere, at least if you had it in the last 10 years, it's sitting somewhere. So what do we do with this? All right, so I don't know if you raised your hand, but you're young and you look like you're infinitely healthy, so I'm going to pick on you. So we could scan you, and we could not only diagnose your torn ACL, right, or your whatever, won't give any problems you don't want to talk about, but we could probably learn a lot about you and use that data to help us take better care of you, whether it be when we're fixing your ACL or whether they're doing heart surgery on you. So the idea that we kind of came up with is when you have patients, they have a scan, when you do big operations, you're usually looking at the cancer, you're looking at the blocked artery or something like that, taking at the liver that you're going to take out. But there's all this other information in these images that we could potentially use to identify high-risk patients and then focus our resources on patients who aren't going to do well. And I'll tell you this, the young man in the back, what's your first name?
I'm Ben.
Ben?
Yep. Ben.
So I am a surgeon. I could do anything to Ben, and he would be fine. I could take his leg and sew it to his arm, and we could keep him alive for a year because he's so healthy. Because that's obvious. So, but the people who aren't, you can't really do anything to them. You have to identify who those patients are. So, Ben, who of these two people look sicker? I don't know if this projects at all. Does it project at all?
Yeah, I can see it from here.
All right. So this is Dr. Words down here. They need a liver transplant. That's not necessarily relevant. Who looks healthier?
The one on the right was healthier than me.
Why is that?
It's brighter. It just looks like it's more active. It looks more engaged.
All right. Good. You're right. So, and I'll tell you clinically what the difference is here is they're kind of fat. Ironically, is fat bad or fat good? Most people die skinny, right? So there's a certain amount of fat that is bad, but in general, a little bit of fat is good. So this guy has some fat. This patient has big muscles. Okay, they got their bone density is bright. You see this? They talk about bright. Yeah, it's hard bones, kind of simple stuff. You figure old ladies with kind of little bone. You see that this is the aorta or the iliac arteries. There's no calcium in there. They don't have calcified arteries. So this has nothing to do. We're not even looking at the liver. This patient needs a liver transplant. But the moral of the story is we can tell lots about these images. We measure. This is one example of trunk muscles. So this is your spine. These are your muscles that go down your spine. Anyone work out and they say work the core. This is your core. This is the muscles around your spine and inside your abdomen that kind of do this and do this. That is your core. It turns out those muscles essentially tell an amazing story as to who's going to do well or not. It goes back to the wheelchair. sitting in a wheelchair, your core is pretty weak. So I only show 2 pieces of data. Part of my job is I do research, and I know that's boring for everyone, but if you take 4 groups of patients who need who had a liver transplant, and you break them down and you hold everything similar, so the same age and type of disease and how sick they are, and you just look at one factor, how big their trunk muscles are, how big their core is, you can really figure out who's going to do well. These people, only about 4% of them died a year after transplant, and the people who are going to do lousy, so almost 35-40% of them died within a year. So in transplant, it's all about allocating to the right people. You're probably the people here, everyone's dying on the wait list, so you probably got to invest your organs in these people who are going to do better. That's kind of the take-home message here. Not necessarily relevant for here, but at least if this isn't transplantation, if this is aortic surgery or heart surgery, these are people that you got to look out for. And I'll tell you how we're kind of doing that. So the big picture on this is we spend a lot of time looking at, you're on the radio about looking at your gene, figuring out what diseases you're going to have. The big thing now is kind of what you eat and the bacteria in your body, and they're affecting whether you're fat or you're skinny or you're smart or you're not smart, things like that. But the bottom line is when you're going to have something major, if you look at the actual body of someone, this is all of these things have been going on for 5 to 100 years, depending on how old the patient is. We can get a good kind of fingerprint of health. And we haven't necessarily looked at that within the context of kind of non-surgical health, but we are doing that. So let's say, here's the story. 7-year-old gentleman, it's kind of the average age of an American who needs a major operation. And I think 70 for a physician is about, you're not really old, you're not really young. 7-year-old guy, we say this all the time, looks older than their stated age. I don't know if you can see it, but the guy looks older than 70. And then you got 70-year-olds who don't, and who we all aspire to be. So how do you take care of these patients differently? Yes. So how do you figure out who they are? Well, we can measure it by their CT scan. So this is just one little study we did that's kind of fun. Same metric. These are middle-aged people who needed big operations. The ones who looked older, so you could take their profile and we look at all these healthy people and we can basically scan Ben. Ben, you're not a good example because you're so darn young, but we'll take Ben anyway. We could scan Ben and we could say, all right, Ben's 28 in real life, but on the inside he's 18, or on the outside he's 65. And 18 just kind of, it's a good way to talk about our vocabulary as to how sick someone is. So if he's 65, we might want to take pause when we're deciding how we're going to take care of him. More relevant to a 7-year-old. 7-year-old on the inside is 100 years old. It's very different than a 7-year-old who on the inside is 50 years old. And basically what it shows, the people who are older on the inside after big surgery have about a 1-year mortality rate of 21%. People who are younger, same age, they're both 55-year-olds on average, their mortality is 4%. So in these scans, there's lots of opportunities to figure out who's going to do well and who isn't. So basically I just told you a story that we as surgeons are trying to figure out who our high-risk patients are. Great. This is a slide I usually have Dr. Campbell's face there. It's like, hey, Mike, thanks for telling me my patients are sick. Any good surgeon, not any, but many good surgeons, that's what you do, right? You eyeball people and you figure out who's going to tolerate what you got and what you don't. But what do we do with these information is kind of the take-home point of this slide. Well, 2 things. One is, as we understand what risk really looks like, we can essentially identify our high-risk patients. And that will inform a couple things. One is if we could do it real time, so Ben's going to have surgery, and we can know what the risks are in front of us. You could say, all right, we could have strategies to make sure he gets all the care he needs. He needs to go to the ICU. He needs to get this. He needs to get that. 2 is we can maybe decide not to operate on him. Sorry, Ben. This is kind of ridiculous. It's not relevant for Ben, but for great grandma whose colon's obstructed, they're hard conversations to have. The data is about 1/3 of Medicare recipients in the last month of life have major surgery. Not hernia repairs, but major surgery. So lots of resources in the last, towards the end of life. And then the other thing is what Dr. Campbell alluded to is if we can identify what the risk, we can better take care of them, but we can also potentially train patients. That's what I'm going to talk about now. Actually, I'm not. I'm going to do this. Ben, since you're young, I'm going to ask you to do something for me here.
All right.
I'm going to change technology. This is high-risk move in the middle of a talk. But the reason Dr. Campbell brings me is because I can do technology stuff, I think. All right, so we have the MSQC. That's what Dr. Campbell talked about. We have data on a couple 100,000 patients. One thing we struggle with as a clinician is care happens quickly, decisions happen quickly, and that data is not necessarily where you want it at any given time. So we can take all of the data that we have. It could be CAT scans. It could be all of this data that the nurses collect. That's Niagara Falls, where I was 2 weeks ago. All the data that we collect on these patients, and we could potentially use it to help us make better decisions about Ben. I'm saying we, meaning primary care doctors, surgeons, and then Ben and his family. So how do we do that? It's really hard to break into the flow of clinical care because of how fast it works, but we came up with a way to, small little technological solution to hopefully take better care of our patients in Michigan. So this is essentially an app. It's a kind of prototype of an app. And go on your, it's not an iPad, and go on an iPhone. This is for surgeons. So Ben's having surgery, so let's give Ben a big operation. Let's give Ben a aortic aneurysm repair. Right? That's definitely big surgery. Common operation, about 60,000 done in the United States, about 10,000 a year done in the state of Michigan. Big operation. Let's give him an open aortic aneurysm repair. All right, and this is designed to be able to, a surgeon can do this in 7 seconds. There's good data that no one will fill out something online on an iPhone for more than 7 seconds. More than that, you're not going to do it. So 7 seconds, surgeon can do this. All right, so Ben is partially dependent. He's moderately malnourished. Let's make it a real hard operation. Only a surgeon can kind of tell you that's going to be easy, that's going to be hard. Let's make Ben hard. Let's make him a little underweight. Let's give him an age of 70. All right, let's make him a male. Let's give him some smoking. Let's make it an emergency case. Let's give him some lung disease. Give him a couple problems. So Ben, what do you think with this problem? This is your future, by the way, in 42 years.
It's 70, all right.
What do you think your complication rate will be? How about this? What's the chances you're alive 30 days after surgery?
30 days?
Yeah. I know. You didn't go to medical school.
I'm going to say coin toss. I'm going to say 50%.
50%. I think it'd be better than that.
Better than anything?
Oh no, I take that back. This is not planned. I kind of made it up. But all right, so Ben, you are officially as sick as they can be. So this is just a little tool. We have an odometer, so it's not a great example actually, because let's make them not quite so sick. Because there we go, make them less sick. So basically, this is an odometer. This is kind of for the patient. So you are a 93 out of 100. Kind of driving on the highway, 100 miles an hour is kind of too fast, right? Anything over 80 is kind of too fast. And Ben, you're 93. That sounds kind of fast. And then this kind of specifically says what your complication rate is, mortality rate. And this can go to the primary care doctor, can go to the medical record, go to the surgeons. I think I worked for Dr. Campbell for a long time. I say, Dr. Campbell, Ben's coming in. He's got aortic aneurysm. You need to come in and operate on him. By the way, he's a 93. Dr. Campbell will be like, all right, well, we're going to do this operation instead of that operation. We're going to do X, Y, and Z. And then Ben's family will be like, you know what? Ben's had a great life. I don't want to be flippant about it, but those are very hard conversations to have when things need to happen quickly. It can certainly inform kind of resource utilization and allocation. But what it can really help us with, because the bottom line is 90% of the operations in Michigan and in the United States are elective surgery, so you have lots of time to plan. So let's say let's give Ben another horrible problem. Let's give him pancreatic cancer. Sorry, Ben. Bad thing to have. Ben gets diagnosed. What can Ben do about it? And it's he can't do much, right? He kind of has to wait for when I'm available. I'm a guy. Let's say I do pancreas cancer surgery and things like that. So he gets diagnosed. It's all right. Well, you're going down to Ann Arbor. You're going to see the pancreas surgeons. Okay, that takes 2 weeks. Then you're going to get, that CAT scan stinks, you need an MRI. That takes another week. And then, you have to wait for me, that's another week. And the whole time Ben's thinking, I got pancreatic cancer, let's get things taken care of. So what can Ben do? And this actually struck me at home. My sister had breast cancer a couple years ago. She's a very highly functioning person. And I remember she said, all I can do is sit around here. There's nothing I can do to kind of have any power here. And so what can Ben do? Ben can get himself prepared. So we do the app. We say Ben is high risk for pancreas surgery, and Ben needs to be enrolled in pre-op boot camp, whatever it's called. So we've been doing this, and I'll tell you kind of what we do. It's pretty simple. We identify high-risk patients, and we enroll them in this optimization program we call M-SHOP, and we've been doing it in Ann Arbor, and our ambitions are to do it in the state of Michigan to try to get him optimized. Because the bottom line is, right now, the way we schedule Ben's surgery is around my schedule. And nothing to do with Ben. It's my schedule. And in that interval, Ben does nothing to really prepare besides worry and lose weight and get sick. So in the time, we can give Ben something to do. And we can get him to exercise, so walking. And we have good data showing anyone that can walk in the clinic can increase their walking. We do, respiratory exercise. Dr. Campbell said respiratory complications are about the most expensive and morbid problem you can have after big surgery. You get him breathing, preparing his lungs. Nutrition, obviously, big portion of it. And then relaxation. That's kind of more care planning, family in order, stuff like that. Really try to reduce stress, get Ben optimized and prepared for surgeries, and mostly empower Ben to kind of feel like that he's participating. So we have a bunch of old people exercising. That's the bottom line. And I think when Ben gets that horrible news that he needs a big operation, he's got a really bad problem, he will do what the doctor says. That's the difference. Ben comes in and he's a 20-year-old guy and he goes see his primary care doctor. He's just not going to do it. The data's clear, no matter what. Not going to do it. As surgeons who do big operations, we're in a unique situation to change behavior. And we can do that along with the primary care doctors. They don't listen to their primary care doctors. I do liver transplants. Patients do whatever I say. Because they know if they don't, then they won't get a transplant. So if we make this kind of these changes in the context of surgery, we can have a huge impact. So our patients, 90% of them do what we say. They stop smoking. They feel empowered. And the average time from when decision to operate is to when surgery actually happens in the state of Michigan or the University of Michigan, somewhere between 30 and 60 days. Plenty of time to get prepared. If Ben and I are going to race in a 5K, it's like, Ben, do you want to run tomorrow or do you want to run 6 weeks? I don't know if you run, but you do. All right, bad example. No matter what, you could probably beat me. But nonetheless, probably the answer is in 6 to 8 weeks to really be sure they can beat me, right? So we've been doing this. We've done this in we've done it in over 100 patients in the University of Michigan for the last couple months. This is our preliminary data. Patients do it, and I'll show that data. 2 is we reduce hospital costs, and then this is kind of payer costs. So put in Medicare, Blue Cross, Medicaid, whomever, cost per case, what the University of Michigan gets paid. But I think most importantly, patients are out of the hospital 2 days quicker on average. This is for major inpatient surgery. So it seems that just preoperative optimization just makes sense. It's funny that we've never done it before. No one's really done it. Should optimize patients, particularly if we can invest that training in the really high-risk patients. So I think most gratifying and important is the patients love this. Ben is scared. What can we give Ben to do? We can empower Ben to kind of participate in his own care. And this is just a nice quote from a lady. I think this is our very first patient. I think we've done 130 now, so 130 patients in the program. And I have a whole kind of, I won't read any of these, but patients uniformly love it. And 90% of them who we approach sign up, and the 10% that don't, about 3% of them are just, no interest. The other 7% are trained people. So many of us in the room are probably trained. We're very healthy. We exercise, a couple times a week. These are not the people that do it, but they are also not the people who get sick, right? Most people who get sick are untrained. So what are we going to do next? Well, we're doing this in Ann Arbor. We aspire to do it in the state. We aspire to take these tools like that app and make one for primary care physicians so that they can maybe do some of this, have these hard conversations with their patients who they know well before they even see the surgeon, and then have this information like this to surgeons so they can make better decisions. And then for hospitals, when they identify who their high-risk patients are so they can mitigate some of those risks. And the MSQC with our, relationships in all of these hospitals, and we already have the data platform, we're uniquely well suited to do that. And indeed, this is kind of what we're hoping and aspiring to do. So that is my last slide. Like Dr. Campbell and I'm sure will take questions. Dr. Campbell, why don't you...
Any questions? Sir.
Can you talk a little bit about payment and incentives? You've talked about taking costs out of the system. That's good for most of us, but it means physicians and hospitals are getting paid less. Are you thinking about trying to move this discussion into incentives for payment, or maybe you already have?
I can answer that. Well, I think one of our partners is Blue Cross. I'll say this for this prehab program. They're on board with incentivizing physicians to enroll their patients. They see, the program costs $50, a pneumonia costs $50,000. They see the business case for optimization. So yeah, they have a physician incentive program, and we just wrote a CMS grant, just turned in about a month ago to implement this in the state, and they were a partner in that, and part of that was these physician uplifts, these additional physician kind of payments for participation in programs like this.
As the Blues or any other funding agency sees the potential benefit from this, they'll be more interested in getting more people to do it, and then you have to incentivize the doctors to do it. So I don't know if you mentioned that, Mike, but in those bar graphs, it might have been hard to see in the back. Those data showed a $2,000, more than $2,000 per case reduction in cost just by getting the patients to stop smoking, progressive ambulation, all the whole checklist that we think is important. That's over $2,000 per case. So that's going to save somebody a lot of money over time. And so you want to get more and more of the doctors knowledgeable about it and involved. And so we talked about this uplift fee, which is a differential payment, incremental payment to the surgeons for enrolling their patients in this program. So that's the direction we're going.
And I think when you think about physicians doing more, they assume they need to be paid more. I'll say this, and you might not believe me, but we're really talking about that 10% of patients that physicians kind of don't want to take. I don't say don't want to take care of, it's not the right answer, but you're looking for a way to make them better, because just the harsh reality of being a physician is if your patients are in the hospital for 2 weeks, you're going in for 2 weeks every day. You're seeing them in the ICU, you're talking about their complications. It's the worst part of the job. So I think it might be a kind of a idealistic view, but nonetheless, physicians love this approach to kind of specific interventions. And the way we've designed it, it's essentially physician-proof almost, meaning that's why the app is for. You hit a certain threshold, you need to do it, because we can't really necessarily rely on decision X, Y, and Z, so to speak, to try to checklist these things.
The other thing that I would emphasize is that we were talking about Blue Cross Blue Shield because they've been our sponsors and they cover 50% of the lives in Michigan. But this is MSPC is an all-payer. We don't distinguish on what source of funding there is. It's an all-payer model, but I think for the folks, many of you are policymakers in this room, this is something that would be particularly helpful in the Medicaid population also, I think, because some of these folks are people who really need this kind of preparation for surgery. They would have a hard time getting it in any other way, and that's why we're interested in this SIM proposal, because I think the Medicaid savings could be pretty substantial if it was implemented throughout the state.
Is the implementation of Obamacare going to impact this program?
Well, I don't think so necessarily. I mean, we have done it for previously uninsured. We didn't make any distinction about that. They all get the care, so I'm not so sure that it would have.
It's an attitude as opposed to programmatic.
Yeah.
And I think hospitals, some of the kind of the burden of high cost, bad outcomes are shifting. Really payers paid for that. I think a lot of that's shifting towards the hospitals, and slowly but surely. So I think hospitals themselves are becoming more and more interested in this kind of.
In fact, Jim and I have talked in the past about this. We're working on this, Jim. We know who the Medicaid patients are in our system. So it's not that hard to split that out to see what is there a differential effect on the Medicaid population or not, and so we're planning to do that.
And we can definitely, Medicaid patients, I'll just anecdotally, 9% of Blue Cross patients that come to the University of Michigan who need big surgery smoke. 50% of Medicaid recipients. Wow. So it's just, as we all know, it's a different population who have more to gain from kind of not just this, but many of the kind of preventative interventions.
I think another important point that Mike said, that I like this idea that the surgical event can be a life-changing kind of event for folks, and it really focuses your attention on your health. And so it may be a link to lifelong better health habits if you can educate people around the time of that major surgery. There's a funny anecdote. There's a person called Tom Starzl, who is a real icon in transplant surgery, who transplanted a lot of livers, And many of those liver transplants are alcoholics. And his phrase was that the liver transplant was the ultimate sobering experience. And it really was, because the recidivism rate was not very high after you had a liver transplant. But I think you could extend that concept to many other kinds of patients where the smoking cessation, for instance, in Mike's experience, now, I know it hasn't been that long follow-up, but most of those people have not started smoking again.
Yeah, that was my question is, has there been any follow-up with these patients that were part of this study to see if the healthcare benefits from the rehab have continued?
I don't think we can really answer that question, to be honest, simply because we've been doing it for 9 months. And the average patient's about 64 years old, so I don't know if we can answer that.
But we will, that's part of the, as Michael said, we've submitted a grant to the CMS Innovation Center for, and the grant was basically, can we extend this, not just in the University of Michigan, can we apply this throughout the state, and what kind of benefits, both short and long term, will we see? Sir?
One of those charts in the first presentation showed the hospitals on an XY axis according to, like, I think the readmission rate or the repeat rate on surgery. Is there any thought to giving this information to consumers and public so that they can start choosing hospitals on the basis of this kind of information?
Yeah.
I'm going to duck on the ground and let Dr. Campbell answer that.
No, I think I'm all for transparency. I want patients to know about hospitals. I think we're kind of in an evolutionary kind of idea about this, and I think the consumer deserves to know certain pieces of information, but the information has got to be good information. It can't be full of holes and misleading, and I think we haven't quite got to the point where we're level. For instance, what do you tell them? Because a hospital performance, for instance, one thing that I noticed is that hospitals, they vary a lot. One year they're pretty good, the next year they're not so good. And so, the consumer wouldn't see that if they were going to see it on a yearly basis, for instance. And then it depends. Another thing I found out is hospitals can be very good in one particular area, not so good in another area. And so how do you communicate that in an easy way to understand? Those things can be solved, but we just haven't done it yet. Yeah.
Like you said, the surgeon is one of the keys, obviously, to these things happening. So one of the 52 hospitals that are participating, what proportion of the surgeons practicing at those hospitals are participating in
MSQC? Well, that's a very good question. But the way we've done it now, it's a hard question to answer, but there is a surgeon champion at each hospital that comes to all our meetings and is responsible for getting the information back to the rest of the rank and file surgeons at their hospitals. So but I do know that one thing that we didn't have time to talk about, but I think is really exciting, is that it's now possible for MSQC to provide data on the performance of each individual surgeon, not at a hospital level, but the individual. So I could show you a graph of 287 general surgeons who practice in the state of Michigan, and I could point to my performance with regard to any number of parameters in the continuum of those 287 surgeons. So that is going to be really important because, as I mentioned before, surgeons are competitive. And if they see that they're not in the right part of that curve, they don't like it. And I think that will get more and more surgeons to be involved in our program that might not be now.
Regarding that chart of the 52 hospitals, I believe you were showing that you could see where your hospital ranked.
Yes.
But you didn't know who the other hospitals
That's right.
were. What's the rationale behind
To avoid, well, there's two things. First of all, we want to avoid that competitiveness part of it. So you could see where the hospital across the town is compared to you. You might be inclined to, make some sort of message about that. The second thing, it's been very important that Blue Cross Blue Shield doesn't know the identity of any of the hospitals, because we couldn't get hospitals to participate if they thought that Blue Cross Blue Shield was going to know about this. It was a strict firewall between what we do and what the Blues know, because the hospitals would be concerned that some sort of differential reimbursement will happen based on whether you're good or bad. And the whole concept of what we're trying to do is avoid that, because the people who are struggling need to feel safe in saying, we're struggling, can somebody help us, without fear of exposure, so to speak. Oh, no.
The MQSC is a state program right now.
Yes.
And you're extending it, I think, to going to work with critical access hospitals. The lines that you showed a dramatic improvement in Michigan. It did show some gradual improvement. I don't remember if that was nationally or not. Do you foresee in 2 years, 4 years, 6 years, extending this so that, in fact, these best practices can be shared among states and all of that, so that there is a more robust sharing of these kinds of programs?
It's a great question, and the answer is yes. We've had several inquiries from different states who are not Shield. For instance, we've been to South Carolina and Philadelphia, and the Kaiser group is interested in it because it's been more effective than what's been done in the past. So I think right at the moment we are trying to think, what's the business case for going outside of the state of Michigan and exporting it to other places, and I think that is what we. And then you can consider what I would call a network of local networks, and there could be one major coordinating center, but you have to let the local people do what they think is important. When the feds or the American College of Surgeons or somebody tries to say you must do this to a regional area, they don't like it, and they usually don't do it. So I think you have to let the locals decide what they think is important, and that's what we did here in this state. Sure.
In the aggregate, do you have any evidence yet whether the collaborative will increase the amount of time a provider is able to spend with a patient, say during an average work week? You mentioned, for example, that nurses collect the data. Does this mean more work for them and less patient care?
Oh, that's a good question, but what the Blue Cross Blue Shield folks support is the salary of a designated nurse. That person has not got any clinical responsibility at all. They sit in front of a computer and they pull all this data out for. And the reason we like that is because that's more reliable than using billing data, what's called administrative data from a computer with full holes, was never designed to measure quality. And so we have a professional, educated nurse pulling all that data out. So it really wouldn't impact that at all. Back to you.
When you were doing the study, did you break down by the type of complication and, more importantly, did you either discriminate or give the same weight to hospitals that might be magnets? Say for example, designated trauma centers that may have higher death rates.
Yeah, that's the concept of risk adjustment. I didn't have to go into that, but it's a really important issue because there are hospitals that take care of really sick patients routinely. Other hospitals, it's just the nature of things. Other hospitals take care of pretty simple cases, and that's fine. But you have to be able to build that into your model that would take account of that. So the playing field is leveled, and all the data that I showed you actually was risk adjusted for that reason. And you still see that variation, even though hospital A's got lots of smoking, diabetic, old people, and hospital B has got the opposite. That's taken into account in the risk adjustment model. Okay, well, thank you very much for your attention.
Thank you so much, Chief Medical Officer Campbell and Dr. Michael Englesbe. Boy, I tell you, when we talk about affordability in healthcare and we talk about the Michigan Surgical Quality Collaborative, do you see how they took some of the fear factor out of it, though? Boy, were they just so engaging. And we just thank you again for taking the time to be here. And on behalf of the Wolverine Caucus, the UM Alumni Association, and the Office of the Vice President for Government Relations, we have these wonderful commemorative Wolverine Caucus pins, 14 karat gold, as a show of our appreciation
today. Put it right next to my other one.
And also, just wanted to acknowledge a few folks who had an opportunity to join us today. State Senator Hoon-Young Hopgood is here. Representative Pete Lund was able to join us, and Representative Martin Howrylak. And also, our Vice President for Government Relations is here, Cynthia Wilbanks. And our new State Relations Director, who many of you already know, Rebecca DeVoot, was joining us today. And I want to mention Rick Bossert. Thank you, Rick, for all that you did from the UM Health Systems to help us make this event possible today. And of course, we appreciate the director of the Michigan Department of Community Health, Jim Haveman, for being here with us today, too. Thank you, Jim, for joining us. And on behalf of, again, of the University of Michigan, we thank you for your support of the Wolverine Caucus this year, and we look forward to seeing you again in January. So we wish you health and happiness. Thank you again.
No, I got one. No, I would say that.